Guys, I got this excellent question the other day asking to go into detail about CMS's new access payment model that they're launching later this year. And before I even start, I want to make this clear and set expectations. This has nothing to do with getting rid of Medigap, MA, Part D, Part C. You get the idea. It has nothing to do with that, and it has nothing to do with making some doctor rich. What it does have to do, however, is CMS's new payment schedule to some people who deal with Medicare. So let's dive into this. Probably a 5, 6, 7 minute Medicare Minute. I'm Ansel, and let's get into it. All right, if you haven't seen yet, Medicare has a new payment model that's pretty unique. It's called the ACCESS model. Now, historically, Medicare has paid doctors or their claims as fee-for-service, right? The physician sees a payment, they get to bill Medicare, and then Medicare pays the claims. CMS didn't really seem to love where that was heading because their costs kept rising, the outcomes for members weren't necessarily improving fast enough, and nobody has been held accountable for the patient's experience. So CMS has introduced what's called the new access model or value-based model. Now, it's not replacing fee-for-service immediately, right? It's a 10-year model to see how things work. And it's where you're going to see models like the new ACOs and MSSPs and the new REACH, and now we have this access model coming into play. All right, let's dive into it and hear me clearly on this. Physicians are still going to be paid the same way for visits and procedures that they have been, right? This quality money, though, I'm going to tell you about that they're receiving is separate. So this incentive or penalty comes later, and it's based on total cost of care, avoidable hospitalizations, patient or client readmission, preventive care compliance, and how someone's chronic condition is being managed. So this new access model is not about a one-time appointment with the member. It's about a year and really over the next decade of outcomes with patients. Now, there's a lot of confusion behind it, and people are scared of these things. You know, most doctors aren't individual. They're a part of a group or maybe an IPA or one of these new ACOs, or they're in a health system and they've been that way for years, right? So when CMS talks about bonuses in this access model or shared savings, that money's going to go towards the organization first, and then the organization can trickle that down to their doctors, or they could reinvest that into infrastructure instead, right? So you're going to hear from a lot of doctors or the AHA, you're going to hear them say that value-based care is coming, but it's not going to change my paycheck. And that's not entirely true. It could, and it could change it for the better. Or, you know, if there's an overabundance of hospitalizations, more readmissions, it could penalize. So let's get into the pro side of things, because I know there's going to be some pushback with really what's happening, because there's some strong opinions on both sides. And we'll be fair here. There are some real benefits to the access model that we're not currently seeing just in fee-for-schedule Medicare, right? So the pros of the access model is it will focus on outcomes, not just volume or how many people the physician can see in a day. Right now, doctors are rewarded based on how many people they can see and not necessarily on patient's outcome, right? That's a problem. Number two, there's going to be an incentive to coordinate care. So there's more communication then between the primary care, specialist hospitals, post-acute care, and the actual networks that a physician is working with. Preventive care finally will matter financially. So things like screenings, medication adherence, and follow-ups will actually impact what kind of bonuses or payments are being paid out to these organizations. And finally, long-term cost control, because CMS is trying to stabilize Medicare for the next generation. It's not looking just to budget for 2026 or 2027. Now, on the other side, there are some cons, and you know, there's a really big one. The first is this: doctors will be able to take on more risk without full control. They're responsible for the patient's outcome, but patients ultimately can still make their own choices, right? And there's a large administrative burden that's going to explode from this. It's going to require more reporting, more metrics, more compliance with CMS rules, and less time with the patients because the doctors will be charting these things. And, you know, incentives don't always reach the doctor, right? Bonuses could stop at that higher organization level and never trickle down. And these smaller practices are going to be squeezed with time that larger systems can absorb that risk, not necessarily small independent physician offices. And quality isn't always measured clinically, right? That doesn't always capture how complex a patient's health or social factors or real world medicine and how it's affecting a member is. So CMS is not doing this to pat a doctor on the back and say, good job. They're doing it to help Medicare spending because it's unleashed. It's off a leash. Fee for service alone is not sustainable by itself without some kind of quality metric as a tool. Maybe not the mission, but as a tool. So doctors are being paid for what they're doing, fee service, but now they can receive bonuses for quality care. And that's only if it gets passed down to them from their top of their organization. And that's going to be a unique thing to watch, right? Because if the organizations at the top who are ultimately getting these quality control bonuses are keeping it for themselves, then what's the point of all this? All we're doing is putting more money, more tax dollars in the back pocket of someone who has nothing to do with treating health care, treating patients, and prescribing things to the members of traditional Medicare to give them health access and benefits that they wouldn't have without these physicians. So ultimately, here's going to be the big question. Will people be in a better place from their physician if we treat them based off quality of care and longevity, rather than seeing how many people we can bring in to get paid a certain fee schedule price? Yeah, absolutely. But only if we see those dollars passed down. And that, I think, that's worth waiting for.